Hey, everybody. I'm Dr. Matt Antonucci, and I'm here with my colleagues, Dr. Jeremy Schmo and Dr. Paul Brewer, both faculty members of the Carrick Institute. And we're super pumped to talk to you about something that's brand new at the Institute, never been done before, an idea that we're all super excited about. And the name of the course that we're going to be teaching coming up real soon is called Mastering Clinical Integration in Patient Care. And this is going to be a series. So this is kind of like episode number 1. And it's going to be the three of us, good friends, good colleagues, people work together, guiding you in this journey for this new course. So I guess we'll take 2 seconds just to kind of introduce Dr. Paul Brewer. Dr. Paul Brewer, he is a optometrist with a specialty in neurooptometry, who has a whole lot of experience in sports neurology, sports vision, concussion, and coming at us with this perspective of optometry. Dr. Jeremy Schmo has been a faculty for forever. He and I studied together originally, went to not chiropractic school, but studied in Carrick Institute together, took our boards together, and been really good friends ever since. We worked together in clinical practice. And Jeremy has a unique specialty, the ability to take really complex ideas and make them really simple and, most importantly, hands-on and applicable. I mean, great hands, great ideas. He's scrappy when it comes to putting together clinical applications for that patient particular. And, my specialty is more in the realm of concussion. I've been teaching for the Carrick Institute now for 13 years. So we're super excited to be able to host this course. So maybe Dr. Schmo, can you talk to everybody and just let them know a little about what you're thinking they're going to get out of this course, and maybe how this framework of this course might be a little different than other courses they might have taken before.
Yeah, for sure. I mean, in your typical courses, obviously there's an outline, there's a PowerPoint, and you're going through the information and everything's kind of flowed out for you in terms of what you're going to get. With this course, it's going to be free flow. We're going to be doing everything from the diagnostics and history and intake, breaking all that information down, and we're going to have a conversation. So, I might say, I see A, B, C, and then I go, Matt, what did you see there? And then you're kind of going to go off on your flow, and then we're going to take Paul's input. So we're going to get multiple inputs, different perspectives. And then my staff is also going to be running diagnostics on that individual that we choose to be the patient during that weekend. So we're going to get BNG, saconometry, posturography, and some other testing that you guys might not have ever seen before. So we'll be doing ready tracks, or actually basically doing like a laser scan of the retina, looking at the most smallest movement that you could ever imagine. So we're going to be bringing in a lot of information. We're also going to show you all the low-tech things that you can do if you don't have all the technology. So it's not all going to be, hey, you have to go buy all this high-tech stuff. We're going to do low-tech, we're going to do high-tech, and we're going to work this person up. We're going to develop a whole rehabilitation strategy, tell you what we would do, number one, in clinic, and then what we would actually do for the patient at home. Like, what are strategies and things that you can do to have them follow up over the next 4 to 6 weeks to make major progress. And that's the thing that I think people have a hard time with is, all right, they left the office. What can you do to make their at-home program the best at-home program with actually not using a lot of technology for that individual? So they don't have to go spend $4,500 on a laser or, a vibration plate or something like that. Like, what can we do tech that's very specific, that lines up with what we found to get them moving in the right direction? So it's going to be awesome because you're going to go into more of kind of this visual aspect, probably concussion, everything that's going on vestibular. And I'm going to bring in more of this kind of like structural neck integration component to this, as well as, visual vestibular integration. And Paul's really going to like deep dive into eyes and really look at that visual system in a way that I don't think people have ever experienced before in a Carrick class. So I think it's going to be pretty awesome.
So let's give everybody maybe a taste of what this might look like. So we're going to have a volunteer patient who's going to come in. They're going to fill out some paperwork. Let's just say that patient says, one of the things I complain about is blurry vision and headaches. Dr. Brewer, what would be your perspective through the lens that you operate on every single day? What's the first thing you think of when you hear somebody has headaches and blurry vision? What are you going to look for?
Yeah, that's a good question, because when you hear blurry vision headaches, a lot of people are they think glasses. Like, do they need glasses or not? And honestly, like, They may need glasses potentially if they've never had an eye exam before. But I'm also looking at different parts of the visual system, like why is their visual acuity blurry? Is there like gaze stability issues? Is there accommodative issues? Is there eye tracking or eye teaming, like binocular issues? So we're going to break the visual system down to all its singular components, because each component can cause blurry vision and each component can cause headaches as well.
So really quickly, so the first thing you think of, okay, so that makes a lot of sense. Blurry vision. I need to check for the refraction. Is there like a simple 2-second test that you can do to see if somebody has a refractory problem? Like something you don't need a whole bunch of fancy technology for?
Oh yeah. So one easy way of doing that is obviously you have a acuity chart to see if they're seeing clear or not. Because they might be saying they have blurry vision, but they might have 20/20 vision, right? So like I actually get a lot of patients where they're like, oh yeah, my vision's blurry, and they're like seeing 20/15, which is better than 20/20. They're like, oh, everything's blurry, So there's a whole perceptual side to blurry vision as well, in addition to are they seeing clear or not. So one test you can do is just get the acuity chart, see how far down they're seeing. If they are seeing blurry, you can do a pinhole test, and when you do the pinhole test, that tells you whether you need a refraction or it might be something else.
Yeah, that's a great example because some people don't even know what the pinhole test is. Now, Dr. Schmo, blurry vision, headaches. Is there something that you're thinking about? Maybe something that's different than something in the eyes that might be a problem?
Yeah, I mean, obviously, there's a lot of changes that can be going on in the upper cervical spine in terms of ligamental instability, proprioceptive feedback that's happening from cervical integration into those nuclei that help you keep your eyes steady. So I'm going to go through a lot of cool ways to look at the cervical spine differently than what you guys have seen before, and kind of add more of that kind of neck integration into what we're talking about.
Yeah, absolutely. And then my go-to is like, are there vestibular issues? Because we know that the vestibular system helps control ocular alignment, integration in that cerebellum. So we need to go one step further and say, okay, let's test the integration to the vestibular system. Let's look at the integrity of the cerebellar networks, and let's look at the integrity of the brainstem networks to see if there's any ocular misalignments causing the blurry vision, or is there some sort of an autonomic problem with pupillary constriction? So I think that this is a little taste of what's going to happen in this class, where we're going to see little things, and each one of us are going to put some input into it and then perform the procedure and tell you what we see out of it. So Dr. Brewer is going to do the pinhole test and say, hey, it gets clearer when they look through the pinhole, so it may mean this. Dr. Schmo is going to maybe do some head tracking and head-eye movements and say, hey, this is messed up, so this is what I would do next. I'll go through and look through the vestibular system and say, this is how we're going to manage this patient. And then the three of us will kind of combine and say, okay, this is what a care plan might look like. And then guess what? We're going to take the patient and we're going to do it, and we're going to see what the results look like. So hopefully you guys got a little taste of what this course is going to look like. I know, super excited. I think I could speak for my buddies here on the video that we're pumped about this class. We hope that you join us. We hope that you invite some friends. And I guess real quickly, Dr. Schmo, level-wise, I mean, where is this class going to be? Is this going to be an entry-level course? Is it going to be mid-level? Or are we looking for individuals who have experience with patients and really want to bring some stuff to the table? I guess what I'm asking you, are people going to sit there and learn, or are they going to interact and participate?
Yeah, I mean, they're going to interact and participate, and I would say this is going to be more of an advanced course. All right, so I would say if you've taken other courses, you have experience, this is definitely not an entry level course, and we're going to be going very high level. We're also going to integrate some business strategies and ideas of ways to kind of really implement this in your practice, because obviously everybody wants that. Like, what can I do to be financially more stable? What can we do to really get people to obviously do their homework? So we are going to bring that business aspect to it as well. So it's going to be good because you're getting everything neurooptometry combined with visual vestibular, combined with cervicogenic integration, combined with business strategies, combined with like really high level thinking, and then development of at-home strategies.
Yeah, and let's not discount also how to educate your patients, how to talk to your patients. I think that's going to be a really big thing that I want to hit on while we're here this weekend. So hopefully this excited you. Hopefully you'll join us. Go to thecarrickinstitute.com, sign up for our course. It's Mastering Clinical Integration and Patient Care. This is going to be chapter 1, and hopefully there'll be chapter 500 one day, because we think that these series are going to be well appreciated and well attended and loved by everybody. So thank you for your time today. We hope you join us. And fellas, I don't know about you, but I'm excited. So let's just give one last goodbye to everybody, and we'll see them later.